USMLE style question on acute hemolytic transfusion reaction AHTR. Question: a 62-year-old woman with a history of chronic anemia is admitted for elective hip surgery. During surgery, she receives a unit of packed red blood cells, PRBCs. 30 minutes into the transfusion, she develops fever, chills, back pain, and dark urine. Her blood pressure drops to 85/60 mmHg. Laboratory findings are as follows. Hemoglobin, Strastat 7.0 gram daily pre-transfusion 7.5 grid-tier, serum creatinine 2.1 mg/mg, total bilirubin 4.2 mg/dL, indirect elevated, LDH 650 UA elevated. Urinalysis, hemoglobinuria, no RBCs. What is the most likely cause of this patient's presentation? A. Preformed recipient antibodies against donor RBC antigens. B. Donor lymphocytes attacking recipient tissues. C. Deposition of immune complexes in renal glomeruli. D. IgE-mediated mast cell degranulation. E. Delayed T-cell-mediated destruction of transfused RBCs. Preformed recipient antibodies against donor RBC antigens. Explanation. This patient is experiencing an acute hemolytic transfusion reaction, AHTR, a serious and potentially life-threatening type II hypersensitivity reaction. The rapid onset of symptoms during transfusion, including fever, chills, back pain, hypotension, and hemoglobinuria, is characteristic of acute intravascular hemolysis. Mechanism of acute hemolytic transfusion reaction: 1. ABO incompatibility, most common cause. Recipient IgM antibodies bind to donor RBC antigens, e.g., anti-A, anti-B. This activates the classical complement pathway, leading to intravascular hemolysis, direct lysis of RBCs, hemoglobin release, hemoglobinuria, complement-mediated inflammation, fever, chills, hypotension. 2. Clinical presentation: within minutes to hours after transfusion, fever, chills, flank back pain, dark urine, hemoglobinuria, hypotension, shock, disseminated intravascular coagulation, D. Acute kidney injury due to hemoglobin nephrotoxicity. 3. Diagnosis: positive direct Coombs test, detects antibodies complement on RBC surface, elevated LDH, indirect bilirubin, hemolysis markers, hemoglobinuria, dark urine without RBCs. 4. Management: immediately stop the transfusion, provide IV fluids, diuretics, and monitor for renal failure. Supportive care for hypotension and DIC. Why not the other options? B. Donor lymphocytes attacking recipient tissues. Describes graft versus host disease, GVHD, which occurs after bone marrow transplants or transfusion in immunocompromised patients. GVHD manifests with rash, diarrhea, liver dysfunction, not hemolysis. C. Deposition of immune complexes in renal glomeruli. Describes type III hypersensitivity, e.g., lupus nephritis, post-streptococcal GN. AHTR is type II hypersensitivity with direct antibody binding to RBCs. IgE-mediated mast cell degranulation. Describes type I hypersensitivity, e.g., anaphylaxis, urticaria. AHTR involves IgM-Ig antibodies against RBCs, not IgE or mast cells. E. Delayed T-cell-mediated destruction of transfused RBCs. Describes delayed hemolytic transfusion reaction, DHTR, which occurs days to weeks after transfusion and involves memory T cells. This patient's reaction is acute within 30 minutes, not delayed. Key takeaways for USMLE. AHT Type II hypersensitivity. IgM-IgG antibodies complement. Rapid onset during transfusion with fever, hypotension, hemoglobinuria, commonly due to ABO incompatibility. Management: stop transfusion immediately. Supportive care. Would you like